I have a bill on my kitchen table. I have had a bill on my kitchen table for most of my adult life. Sometimes it is a different bill. The table is always the same. I want to talk about healthcare. I want to talk about what it costs and who set the price and who is protected from the price and who is not, and why those two groups break down almost exactly along generational lines in ways that are not accidental and are not the market and are not bad luck. They are policy. They are choices. They have names attached to them, and the names have voting records, and the voting records are public. I'm going to give you the facts. I'm going to give them to you plainly because the facts do not need decoration. The facts are sufficient on their own. The facts are, if anything, more enraging without the decoration. So we will do this without the decoration. 100 million Americans are currently carrying medical debt. That number comes from a 2022 Kaiser Family Foundation analysis. 100 million. That is not the number of people who got a big bill once and paid it. That is the number of people carrying it. Right now, on credit cards, in collections, in payment plans, in the back of their minds when they consider whether to go to the doctor this time or wait and see. Medical debt is the number one cause of personal bankruptcy in the United States. Not gambling, not bad investments, not irresponsible spending, going to the hospital, getting sick, breaking a leg, having a baby, having a heart attack, having the heart attack, and then opening the bill and having a second one. This is not a natural fact about the universe. It is not written into physics or biology that getting sick should cost you your savings. It is a policy fact. It is the result of a specific set of decisions about how healthcare gets paid for and who bears the risk and who captures the profit. Those decisions were made by people in rooms that most of us were not in. The people in those rooms were not bad people necessarily, but they were mostly not people who had ever sat at a kitchen table at midnight doing the math on an explanation of benefits form and coming up short. And that absence shaped every decision they made. 100 million Americans currently carry medical debt. The number one cause of bankruptcy in America? Medical bills. This does not happen in Germany, France, Canada, Japan, Australia, the UK, South Korea, or any other peer nation. This is not bad luck. This is architecture. Let me tell you what health insurance looked like for a working person in 1975. Not for a wealthy person, not for a senator, for a person who worked at a company with more than a few hundred employees, which described a large share of the working population in the post-war era. In 1975, the average employer-sponsored health plan covered roughly 80 to 100% of medical costs after a small deductible. The deductible was typically $50 to $100 per year. Per year. You paid $50, and then your insurance paid for almost everything else. Hospitalization, surgery, prescription drugs, specialist visits. The plan covered your family. The employer paid most of the premium. Your out-of-pocket exposure in a catastrophic year, a cancer diagnosis, a serious accident, was capped at a number a working family could, with difficulty, survive financially. That was the system for a significant portion of working Americans for roughly 30 years. From the early post-war era through the 1980s, it was not universal. The poor, the self-employed, the part-time, the workers in small businesses without benefits, they were always exposed. The gaps were always real and always cruel. But for the unionized worker, for the large company employee, for the government worker, for the person who could get a job with benefits and stay there, the coverage was real. It paid. It protected. The boomers came of age inside this system. They got their families covered. They got their children's births covered. They got their parents' late career illnesses managed with insurance that actually functioned as insurance, which is to say, a mechanism that pooled risk and prevented individual catastrophe. That is what insurance is supposed to do. For a while, in a limited way, for certain workers, it did that. Then it stopped. Before we get to how it stopped, we need to understand why employer-based insurance existed in the first place, because it was not the natural order of things. It was an accident of World War II that became a system, that became an assumption, that became a trap. During World War II, the federal government imposed wage freezes on employers to control inflation. Employers could not compete for workers by offering higher wages, so they competed with benefits. And the IRS, enrolling in 1943, decided that employer-provided health insurance was not taxable income. That tax exclusion made health benefits an extremely efficient form of compensation. $1 of health benefits was worth more to a worker than $1 of wages, because the wages got taxed and the benefits did not. The employer got a deduction. The worker got untaxed compensation. Everybody in the room at the time benefited. The decision locked in a system. The problem with this system was always structural. It tied your health care to your job. Lose your job, get fired, get laid off, become too sick to work, start a business, go freelance, and you lose your coverage. The coverage was never yours. It was always the employers to give and the employers to take. The American worker did not have health care. The American worker had access to health care through an employer who could change the terms at any time, reduce the benefit at any time, switch to a cheaper plan at any time, and eliminate the benefit entirely as soon as doing so became cheaper than maintaining it. And that is exactly what happened. Slowly, then quickly, then as policy. The system was never designed to protect you. It was designed to attract you. When attracting you became expensive, they found cheaper ways to attract you. Your coverage was a recruitment tool. When the recruitment calculus changed, so did the coverage. The mechanism by which coverage degraded for younger workers is called the high-deductible health plan, the HDHP. You know this plan. You may be on this plan right now. Let me describe it so we are all using the same language. An HDHP has a low monthly premium, the amount you pay every month to have the insurance. It has a very high deductible, the amount you must pay out of pocket before the insurance pays anything at all. In 2024, the IRS defines a high deductible plan as one with a deductible of at least $1,600 for an individual or $3,200 for a family. In practice, many HDHPs have deductibles of $3,000, $4,000, $5,000, even $7,000 for individuals. $7,000 before the insurance pays a cent. For a person making $45,000 a year, that is more than 15% of their gross income before taxes. 15% gone before insurance touches a dollar of it. The HDHP was sold as choice and empowerment. You pay less each month. You are a healthcare consumer now. You have a health savings account. You can shop for care. The theory was that if patients had skin in the game, they would make smarter healthcare decisions, and the market would allocate efficiently, and costs would come down. That was the theory. The theory was wrong, and there is now significant evidence that it was wrong, and the evidence has not changed the policy because the policy was never primarily about improving outcomes. It was about shifting costs from the employer to the employee, and the theory was the branding on the shift. What actually happened is documented. When people face high out-of-pocket costs, they delay care. Not elective care, necessary care. They delay the follow-up appointment. They skip the prescription refill. They decide to wait on the lump and see if it goes away. They go to the emergency room instead of a primary care doctor because the ER is legally required to treat them and they can negotiate the bill afterward. Delayed care produces worse outcomes. Worse outcomes produce higher costs down the line. The HDHP saved employers money in the short term and shifted the long-term costs and risk entirely onto workers who were the least able to absorb it. Let's look at some numbers. In 1980, the average employee share of health premium was about 0%. In 2024, the average employee share of health premium was about 28% for individuals and about 47% for family coverage. The average HDHP deductible in 2024 was about $2,500 to $7,000 per individual. The median millennial savings was about $4,800 total. Translation: one bad health year wipes out the median millennial's entire savings. The boomers who are retired now mostly locked in their coverage before the HDHP became standard. They have Medicare. Medicare has a deductible, but it is manageable and it has supplemental coverage options, and it is administered by the government, which means it is not trying to generate a profit from denying your claim. They have, in many cases, retirement health benefits from the employers they spent careers with, negotiated when those employers were still willing to negotiate. The floor is under them. The floor is not under you. You got the high deductible. In the HSA, you cannot afford to fund an explanation of benefits form that explains nothing except how much you owe. And then you were told to be a smarter healthcare consumer. I want to talk about the uninsured years, because I think this is the part that gets left out of the policy conversation, and I want to fit it in this one. There is a period in most millennial lives, and in most Gen Z lives, and in many cases it is not a period, it is a recurring condition, of being uninsured, of doing the math and concluding that the cost of insurance exceeds what you can pay and that you will just be careful. You will not get hurt. you will not get sick. You will eat well and sleep enough and avoid the things that break bodies, and you will just get through this period without coverage and pick it up again when the job changes or the income improves or the government program opens up or something shifts. And then something happens. It always happens. A car accident, appendicitis, a fall, a fever that won't break. The thing you were being careful to avoid finds you anyway because bodies do not honor the financial agreements you made with yourself. And you go to the hospital, and the hospital treats you, and then the bill comes. And the bill is not $23,000 if you have insurance. The bill is $48,000 because you do not, because the hospital charges uninsured patients the full sticker price, the charge master rate, which is a number that exists in no other industry, a price that almost no one actually pays, a price that is set high specifically so that insurers can negotiate it down and look like they saved you money. Without insurance, you pay the sticker price. The sticker price is a fiction written to make insurance look like a discount. You know this system. You have been inside it. I want to name it plainly, because name it plainly is the first step toward refusing to accept it as normal. It is not normal. It is specifically, exceptionally, documentably American. I want to give you the international comparison, because it is the single most clarifying set of numbers in this entire conversation, and it does not get said enough in plain language. The United States spends approximately $12,500 per person per year on health care. Per person. Every man, woman, and child in America, averaged out $12,500. Germany spends about $7,300. France spends about $6,000. Canada spends about $5,800. Japan spends about $4,800. The United Kingdom spends about $5,000. Australia about $5,600. Every one of those countries covers every one of their citizens. Universal coverage. Nobody goes bankrupt from a hospital bill. Nobody delays a cancer screening because they cannot afford the copay. Nobody dies from a treatable condition because they were uninsured. Medical debt as a cause of bankruptcy is not a concept in those countries. It does not exist. It is as foreign to a German or a Canadian as the idea that you might lose your house because you got sick. They literally do not have a framework for understanding it because it does not happen there. We spend 2 to 3 times what they spend. We do not get 2 to 3 times the outcomes. On most measures, life expectancy, infant mortality, chronic disease management, cancer survival rates when excess is controlled for, we get worse outcomes. We spend more for less. And then we are told the problem is that we have not fully embraced the market yet. That if we just removed more regulation and introduced more competition and made patients into better consumers, the efficiency would arrive. The countries beating us are not less market-oriented because they are less free. They made a collective decision that healthcare is a thing you provide your citizens the way you provide roads and courts and fire departments. Not because it is a charity, because a population that goes bankrupt when it gets sick is not a productive population, and a government that lets that happen is not governing well. It is a practical decision dressed up in moral language, and it is the right decision, and we have refused to make it for 50 years because the people who profit from the current arrangement have been very effective at making sure we don't. We spend $12,500 per person per year on healthcare. Germany spends $7,300 and covers everyone. The difference? $5,000 per American per year is not better care. It is profit. Follow it. I cannot do this monologue without the drugs. I have to talk about the drugs. Insulin. Let us start with insulin because it is the clearest example of what happened and because people die from it, and that should be in every conversation about American drug pricing until it stops being true. Insulin was discovered in 1921 by Frederick Banting and Charles Best. They sold the patent to the University of Toronto for $1. $1. Because they believed, and Banting said this explicitly, that a life-saving medication should not be owned by a private company for profit. That was the founding moral position of the drug that keeps diabetics alive. $1. The patent given away on purpose. In 2019, the list price of a single vial of insulin in the United States was approximately $300. In Canada, the same vial cost about $30. In Germany, about $11. The insulin was the same, The molecule did not change at the border. The price changed. The price changed because American law, shaped by decades of pharmaceutical industry lobbying, does not allow Medicare to negotiate drug prices the way every other developed nation's government negotiates drug prices. The industry wrote that provision into law and funded the campaigns of the legislators who kept it there, and the people who could not afford their insulin rationed it, and some of them died from rationing it, and the quarterly earnings reports looked excellent. The Inflation Reduction Act of 2022 finally capped insulin at $35 a month for Medicare patients. It passed. It was a real and meaningful change. It was also 40 years overdue, and it only covers Medicare patients, and it happened over the vigorous opposition of the same industry that had kept the price at $300 for 30 years. It was a victory. It was a small victory against a very large and very well-funded opponent that immediately began working to limit its scope. The pharmaceutical industry spent, in 2022, $373 million on lobbying. That is more than any other industry in America. More than oil and gas. More than finance. More than defense. The industry that sells you the drugs you need to stay alive is the most politically active industry in the country. And its political activity is directed almost entirely at keeping drug prices high and keeping the government from being able to negotiate them down. This is documented. The lobbying disclosures are public. The money is traceable. And the people on the other end of it, people whose campaigns are funded, whose re-election depends on that funding, who voted year after year against Medicare negotiation, they have full health coverage. Fully covered, for life. The benefit of the job. The one they are doing so badly. I said I would follow the money, and I will. But I also want to follow the votes, because the votes are where it gets fixed, or it doesn't. Every major attempt to reform the American healthcare system in the last 30 years, the Clinton plan in 1993, the public option in 2009, Medicare expansion proposals, drug price negotiation, surprise billing reform, has been weakened, gutted, delayed, or killed by a combination of industry lobbying and legislators whose constituencies skew older and more insured and who therefore face less electoral pressure to fix a system that is failing younger and less insured voters. This is not a conspiracy. It is arithmetic. A senator from a state where the median worker is 61 years old and on Medicare is not going to feel the same urgency about HDHP deductibles that a senator from a state with a younger population will feel. The median voter's experience of healthcare is different. Their coverage is more stable. Their out-of-pocket is lower. The risk of medical bankruptcy is smaller. And so their senator, responding rationally to the electorate, does not prioritize the reform. I want to be precise here, because I think the healthcare conversation often collapses into a partisan frame that is too simple. Both parties have taken pharmaceutical money. Both parties have watered down reform proposals under industry pressure. The Affordable Care Act, whatever you think of it, was explicitly designed around the insurance industry's requirements, not the patient's requirements. Because the political calculation in 2009 was that you could not pass reform over the industry's opposition, and so you had to bring the industry inside the tent. The result was a bill that extended coverage to millions of people who needed it. That is real and important. And that preserved and in some ways entrenched the profit structures of an industry that was the problem. Both things are true. What is also true is that the voters most harmed by the current system, the young, the uninsured, the underinsured, the people with HDHPs and the medical debt, vote at lower rates than the voters most protected by it. And the voters most protected by it have, in many surveys, reported opposition to changes that might affect their coverage, even changes that would not affect their coverage at all, because they've been successfully frightened by an industry with $373 million a year to spend on frightening them. Fear is the product, confusion is the mechanism, and a confused, frightened voter who shows up reliably is worth more to the industry than an angry young voter who stays at home. You are not absent from this system. You're paying into this system every month. You just aren't in the room when the system gets designed. The room has an open door. The door is called the primary election. 19% of young people used it in 2014. That is why you have the plan you have. I want to say something that the policy conversation usually skips, because it is harder to quantify. What this costs beyond money. There's a particular kind of dread that comes from being uninsured or underinsured in America. It is not the dread of a specific bill, though that dread is real. It is a background dread, a low hum. It is the knowledge that your body, this thing you live in and cannot leave, is a financial liability. that a single bad day, a single diagnosis, a single accident could rearrange your entire financial life, that the arithmetic you've built your survival on is one emergency room visit from collapsing. This dread affects decisions. People do not start businesses because they cannot lose employer coverage. People stay in jobs they hate because the job has benefits. People delay having children, not just for housing cost reasons, not just for wage reasons, but because the cost of having a child in America without excellent insurance is staggering, and with excellent insurance is still significant. People do not leave abusive relationships partly because leaving means losing coverage. Healthcare insecurity is not just a financial problem. It is a freedom problem. It is a constraint on the choices you can make about your own life that the people who have good coverage simply do not face. My friend's father worked at the same company for 22 years. People used to say that was loyalty. Some of it was loyalty. Some of it was that leaving meant losing coverage for a family with a kid who had asthma, and another one who needed orthodontia, and a wife with a chronic condition, and you did not gamble with that. You stayed. The coverage was the lock. Not just a benefit, a lock. And the people who designed the system knew it was a lock, and they used the lock to keep labor in place and suppress wage negotiation and prevent the kind of worker mobility that would have given workers more leverage. The coverage was the leash they called the benefit. And now they have taken the leash off because they have found they do not need it. Contingent work, gig work, the diffusion of employment into contract arrangements. These do not require the leash because they have no commitment to break. You were never employed. You were always a contractor. No coverage owed. No lock needed. Freedom, they call it. You are free. Free to pay your own premiums on the individual market where the prices are higher and the networks are thinner and the coverage is worse. Here's what we do. Here's the actual list. The first thing is vote in primaries with healthcare as a primary issue, not a secondary issue. Not one item on a list of 15. Healthcare specifically. Ask every candidate in every race at every level, what is your position on drug price negotiation? What is your position on the insurance deductible structure? What is your position on the medical debt that is currently crushing 100 million of your constituents? Make them answer. Record the answers. Remember the answers in November and in the next primary. The second thing is support the elimination of the employer coverage tax exclusion in its current form, or its transformation into something universal. This is a policy proposal that does not get enough airtime because it is complicated. But the current tax exclusion for employer-sponsored insurance is worth approximately $300 billion a year in foregone federal tax revenue, and it disproportionately benefits higher-income workers who have better employer plans, redirecting that subsidy towards universal coverage through an expanded Medicare, through a public option, through any number of mechanisms that policy people have designed and politicians have been too funded to adopt, is where the money for a better system already exists. It is already being spent. It is being spent to prop up a system that is failing you. It could be spent differently. That requires changing who makes the decision. The third thing is get loud about medical debt specifically. The Biden administration took steps to remove medical debt from credit reports. That is meaningful. It is also recent and fragile and requires legislative reinforcement to be permanent. Medical debt should not destroy credit scores. It should not be collectible by third-party debt buyers who purchase it for cents on the dollar and then pursue people for the face value. Those practices are legal. They should not be. Making them not legal requires legislators who will act on it, and legislators who will act on it requires voters who demand it. The fourth thing is the hardest and the simplest. Talk about this at the dinner table, at work, with the people who vote and who have Medicare and who think the system is fine for them because right now it mostly is. Show them the international comparison. Show them the 12,500 versus the 7,300. Ask them why they think we pay more and get less. Ask them what they think would happen if their Medicare were privatized and given an HDHP structure. Watch what they say. Most of them will not like that idea at all. Remind them that this is the idea their generation accepted for everyone who came after them without much protest. Not because they're bad, because they were not affected. Because the water is only hot if you are in it. Make them feel the temperature of the water you're in. Not with anger, with arithmetic. The arithmetic is enough. I have a bill on my kitchen table. I have had one there for most of my adult life. The amounts change, the feeling does not. It is the feeling of a system that is extracting money from you for a service it is obligated to provide and finding every possible mechanism to provide less of it for more of your money, and then telling you the mechanism is the market and the market is freedom and freedom is the thing you ought to be grateful for. I am not grateful for it. I want to say that straight up. I am not grateful for a system that produces 100 million people in debt for the crime of getting sick. I am not grateful for a drug pricing structure that kills people for profit. I am not grateful for a deductible that functions as a deterrent to care. I am not grateful for the coverage I lost between jobs, or the coverage I could not afford as a contractor, or the year I prayed I would not break something because I could not afford to fix it. But I also do not want to end on the gratitude question, because the gratitude question is a distraction. It is what they put in the road when they do not want you looking at the road. Whether you are grateful or ungrateful is irrelevant to whether the system is working. A system that produces 100 million people in medical debt is not working. That is not a political opinion. It is a performance evaluation. The system is failing the people it is supposed to serve. The evidence is in the bills on the kitchen tables of 100 million Americans. The evidence is in the bankruptcies. The evidence is in the deaths from rationed insulin. The evidence does not have a party. What has a party is the solution. What has a donor list is the opposition to the solution. What has a lobbying budget and a PAC and 30 years of campaign contributions is the reason the solution has not arrived. That part has addresses and names and voting records. That part you can act on. The bill is on the table. You did not put it there, but you are the one who can take it off. Show up. Vote like your health depends on it. It does. I have a bill on my kitchen table. I know who put it there now. So do you. That is enough to start. Start.